Okay. Just quickly, a lot of you know Jerry. He's, in addition to being a pediatrician that deals with adolescent health, he also happens to be the chair of the Tiverton School Committee, so he's acutely aware of the issues that we're talking about, what we're dealing with. And without further ado, Dr. Larkin.
Okay, thank you. So before I start, I'm always supposed to make a disclosure here. I have no financial or commercial disclosures. I do still have just 3 sons, 3 cats, 1 dog, and 1 wife. So this is how I usually feel when I start to think about or talk about marijuana. And the way I sort of got into this or developed anything bordering a moderate degree of knowledge or expertise is I had 2 patients come to see me a few years ago in quick succession, both requesting medical marijuana. And in a relatively rare moment of self-awareness, I said to myself, I know nothing about this, as do most physicians, and was ranting later on to a colleague about, we really need someone to come and give us a lecture and do a grand rounds presentation on medical marijuana. And she said, well, how about you? And so that's kind of how this all started. I started out as relatively skeptical in terms of medical marijuana, and then actually have come around a bit about that. So that's at least one disclosure. However, I would draw a bright line with use among adolescents and really among young adults under age 25. And hopefully what I can do is give you some of the knowledge that I acquired about, what does marijuana do? Why is it a, attractive substance for people? And what are the risks entailed both medically and psychologically or neurologically in its use. But I'm going to bet that I'm going to leave you just more confused. So 2 important distinctions. So medical marijuana is the use of a cannabinoid, and that's the term used for the active ingredient in marijuana to alleviate some physical malady. And I would agree wholeheartedly with the Assistant Attorney General that the regulatory apparatus around medical marijuana, I think medical marijuana for some patients is a success. However, the regulatory aspects of it and how those are how well those are enforced is rather a disaster, having looked at the regulations promulgated by the Department of Health. Recreational marijuana, on the other hand, is the use of one of these cannabinoids to experience an alteration in the psyche, either perception, euphoria, insight, or introspection. And I apologize if I'm a little bit in the weeds on the medical aspects or biological aspects or neurotransmitter aspects. Hopefully you can ask questions if it's not clear. There may actually be some protective aspects in the use of medical marijuana in terms of the frequency, dose titration, that people will be very careful about how they use it and they know exactly what they need to do to get a certain therapeutic effect. And oftentimes, the more psychic or psychological aspects are a hindrance to their use. But still, about 190 people at last count, there's probably a count since then, globally have used marijuana at least once in 2012. Another interesting thing about medical marijuana in particular, and really about medical marijuana in a lot of regards, is that as opposed to almost any other therapeutic option I can think of, there is very little good data to tell us what to do. Research is somewhat prohibited, both because the restrictions imposed on researchers really are a disincentive to people to get involved in this. And there's a lot of heterogeneity in terms of what people are exposed to, what they're using, and really what they're affecting, what effect they're getting. Another kind of curious aspect of it is that whereas I've never taken a lot of antibiotics or antiretrovirals, I have very, 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 very distant experience of marijuana. So at least I've had, but of course I did not inhale. And perhaps some of you have as well, but you're all now upstanding members of the school committee, so I'm not going to ask any uncomfortable questions. So this map keeps on changing, but basically in the dark green you see where legalization has occurred for both recreational and medical marijuana, and in the paler green for medical marijuana alone, and in the gray states they have not yet done much of anything, I guess. The first state to legalize it was California in 1996. There is actually some support and large medical bodies for recognizing both its therapeutic benefit and that perhaps it is a good option for some patients. Rhode Island legalized medical marijuana in 2006, and it called for 3 dispensaries, although I think there's only one currently that was opened in April 2013. So this is sort of the point of the spear, if you will. These 2 molecules are called endocannabinoids. What that means is that these are neurotransmitters in your body right now which have a therapeutic effect, or have a physiologic effect, I should say, on your nervous system, on inflammation, on a lot of different things. These are what your body makes that looks a lot like THC. One is called anandamide, and that's from the Sanskrit word ananda, which means joy or bliss, and there's this apocryphal story that it was an Israeli scientist who actually first identified this molecule in around 1992, and he was studying Sanskrit, and so they used ananda as the term for the molecule. And someone said, well, you're an Israeli, how come you didn't find something from Hebrew to name it? And he said, well, there really wasn't a word in Hebrew for joy or bliss. Or Yiddish, I guess, which I don't believe is the case. I believe Hebrew is probably a joyous language. So what do these endocannabinoids do? They sort of have an effect of volume control. They dampen down neuronal activity. They can regulate levels of other neurotransmitters that are very important in mood, pain, appetite, motivation, memory. Some of these are called dopamine, serotonin, or endorphins. And this is actually a very important point. They also tend to have a role, or we believe they have a role, and again, this is evolving science, that in shaping brain development by guiding neuronal placement, so the placement of neurons, and activity supporting myelin growth, which is this sort of insulating stuff around nerves. THC may actually interfere with this process because it actually tends to bind the same receptors but more tightly, which is why the endocannabinoids don't necessarily make you high, but THC will. And then in the periphery, they may have an anti-inflammatory role, which is maybe part of the reason why they seem to have an efficacy, at least medically, in pain control. So these are the 2 principal cannabinoids in marijuana. One is called cannabidiol, it's on your left. The second is THC, or tetrahydrocannabinol. And these 2 actually sort of act in concert. The one on the left tends to inhibit the one on the right. The one on the right is the one for the psychoactive effects, whereas cannabidiol probably affects it a little bit, or inhibits it a little bit. There's actually probably 60 or more other molecules similar to these also in the marijuana that you may smoke that also have this sort of entourage effect. So that's important for many different reasons, one of which is that you get different effects from different plants, but also as the Attorney General was telling you, the marijuana available in 2017 is very different from the marijuana that was available in 1966. So the marijuana available now is not your grandmother's marijuana, it's your little sister's marijuana, and she's on fire. So what are some of the potential medical benefits? There has been some evidence that it will alleviate chemotherapy-associated nausea and vomiting, but there's probably other drugs that are better for that. It's also used as appetite stimulation and wasting associated with HIV. Now here I'll make a comment about, again, the medical marijuana regulatory apparatus in Rhode Island. You don't need to have wasting from HIV in order to get a medical marijuana card. You just need to have HIV. And HIV in 2017, just like marijuana in 2017, is very different from HIV in 1986. Very few patients of mine, anyway, have any wasting associated with HIV. There's probably also a component of modulation of pain and possibly a synergistic effect with opioids with efficacy in chronic pain syndromes. And again, this is important for you to know because the debate can't be, I shouldn't say that. People will tell you, I smoke marijuana and it has changed my life. It has really helped me a lot. And I think that the medical evidence is pretty clear that that is the case for some people. And so, again, what I'm trying to do is give you some knowledge about exactly what you're going to hear from community members and others. There may be a benefit for decreased spasticity in multiple sclerosis, and there's some evidence that it may have an impact on certain other neurologic disorders like seizures and Tourette syndrome. So what are the risks? Well, again, these are really hard to qualify or quantify because the exposures are very heterogeneous, and all of the studies have relatively low numbers, or at least studies in medical, looking at it medically or neurologically. And the numbers are often confounded by tobacco and alcohol exposure and underreporting. And again, because the drug is acquired illegally, it's very difficult to know exactly what is the constituent molecules in those drugs. And adulterated preparations may have other particles in them, such as sand or glass or other things put in there to increase the weight. What about adolescent use? And again, I think this is probably the single most important point I can make, is that it imposes the risk at a time of neuronal pruning. So just like you no longer have your grandmother's marijuana in 2017, the adolescent that you struggle with on a continual basis is not the cute toddler of 2 years ago, or hopefully the assured, self-confident, employed 26-year-old you're hoping for in 10 years. So there's a lot of stuff that's going on in adolescence, as we may all recall and still may in fact be experiencing, especially with some other elected officials in our town. So there's a lot of remodeling of the frontal lobes that occurs in this time. There are actually also associated increased rates of schizophrenia and psychosis in susceptible populations. There are associated memory deficits, so as the Attorney General was discussing, performance differences on testing, reduced attention processing, mood disorders, and a greater likelihood of a dependence if it is started in adolescent use or in the early years of adulthood. There's a decreased capacity for learning and memory, especially if started in adolescence. And it's important to recognize that an adolescent may in fact be self-medicating for anxiety or depression, and there is a relatively high association with co-diagnoses of anxiety or depression in chronic users. And so in that regard, their use is more akin to medical users, and that they're titrating for effect. But again, these are kids that actually should be gotten into care and treated with other modalities. So just a couple studies that I'll touch on briefly. There was a longitudinal study of 3,964 Dutch patients, and the risk of psychosis was 2.2% versus 0.8% in the chronic users. So that's a relative risk of about 3 to 1. And then in 50,000 Swedish medical recruits that were followed for 28 years, who had used more than 50 times, there was a 7 times higher incidence of psychosis. And there's an increased risk of psychosis in those already diagnosed with a psychotic disorder, 42 versus 17%, and 61% in heavy users. It is important, again, to understand the caveat that a lot of these disorders actually present in adolescence and early adulthood too, so some of this information may be confounded. However, the differences between, the large numbers plus the differences in incidence between the users and non-users, I think, is rather striking. There are a few other medical risks, some of which, again, I think is getting a bit into the weeds. But I think the thing to understand is that a lot of the epidemiology is not clear, and that does become something of a flag that gets waved by proponents of recreational marijuana. But it is important to understand that, especially with smoking over 20 years, and again, this oftentimes is something that people are embarking on as a lifelong habit, there does appear to be an increased risk of some cancers, particularly lung cancers, if you are smoking both tobacco and marijuana for more than 20 years. There's conflicting studies regarding lung disease, so it's actually, again, because the exposures are rather heterogeneous, it's really difficult to say what the real science is. So dependence, there's a 9% risk overall. It declines with age, and again, is greatest in adolescent use. There is a withdrawal syndrome, as distinct from addiction, I would say, but it's characterized by irritability, anxiety, anorexia, weight loss, disturbed sleep, restlessness, and craving. And again, I think it's important to understand that when you're talking about, at least from my point of view as a physician, when you're talking about dependence, I'm referring to physiologic issues. So if a person is addicted to benzodiazepines and stops abruptly, so Valium, Ativan, those types of things. Someone stops those things abruptly, there is physiologic basis for their need for that drug that can be life-threatening if they stop it abruptly. That is not the case with marijuana. And that, so again, becomes something of a flag that people wave, saying, well, you can't become addicted to marijuana. That's probably true in a purely physiologic sense. However, there is this dependence syndrome, or there is dependency and there is a withdrawal syndrome associated with it. Having said that, as far as I know, a lethal dose has never been reported, which is, again, how this articulates with the opioid crisis is, I'm not even going to get into it, other than saying that. All right. That's it. Thank you.